which is part of the cycle of international presentations about the advanced nursing practices promoted by PAHO Brazil, the Federal Council of Nursing, and the Center for the Research of Nursing in the University of São Paulo, Ribeirão Preto. The objective of this event is to share the international experiences, aiming to subsidize discussions and debates about the implementation of the advanced practice nursing in Brazil. To continue our event, we pass the words to Monica Padilla, coordinator of the technical unit of capacity building for health and from the technical unit of health services in PAHO, Brazil. Welcome, Dr. Monica. Thank you so much, Monica. Good afternoon, everyone. I'd like to thank you for the possibility to meet today here to discuss this very important topic, which is a challenge for all of us, about the scope of practice, nurse practicing, and to ensure a better quality of access and more opportunities for the population in Brazil. Lots of challenges that we have to focus on, and we have to make this all a reality, but we have to understand what are the possibilities to construct and to design, and with the successful experiences and how they can contribute to the partners. The idea of these meetings is to identify those important factors that will allow us to develop a proposal that could be advanced and could take use of the successful experience, and should also consider the mistakes that we should avoid. And then so we can avoid to coordinate stronger efforts and to recognize a professional category that has been increasing and professionalizing throughout time, that could take a set of roles or a set of actions that is necessary to maintain our population with a better health and more quality. Thank you so much, our speaker that will be making presentation to us today, Dr. Joyce, for having this time dedicated to be here with us and to ensure this sharing the knowledge to the people. I would like to ask everyone who is connected to us to send us our questions and comments, and I would like to congratulate everyone for this event, and our partners, our collaborative centers from Ribeirão Preto in the University of São Paulo and the College of Nursing to be able to support us here. Thank you so much, everyone. This is going to be a wonderful event. Thank you, Monica. Thank you very much, Dr. Monica Padilla. And continuing now, I'd like to invite for her introducing words, Professor Nadia, the member of the Advanced Practice Commission. In this act, she would be representing Dr. Betânia Maria dos Santos, President of Cofen. Welcome, Dr. Nadia. Thank you very much, Monica. Thank you so much, everyone present here in this event. I'm here representing, as has been said, our president, Dr. Betânia Maria dos Santos, and I bring here the greetings to our partners in the organization of this event, PAHO, and the Collaborative Center of PAHO, WHO in the College of Nursing in Ribeirão Preto. And I also would like to greet our special partners and our work group together with PAHO, Ministry of Health, Ministry of Education, CONAS, CONASEMS, and everyone connected with us here that has been with us during all these 4 cycles that we had of presentations. And now we already count with over 1,000 accesses. In this last cycle, it was very interesting as well. So we are now in our 4th round of meeting. So we have a lot of users connecting, and this topic is extremely important because it brings the experience and the expertise from several countries, from Europe, from the Americas, which would be very important to strengthen our discussions and debates about the expansion of our nursing practice scope. This discussion started way back there in 2015 when PAHO invited us to it. And since then, we had lots of meetings, organizing lots of events, seminars, and we organized a huge work group that has been discussing how to implement and how to expand the scope of practice and how to prepare these professionals, and also the regulation mainly. And we have no doubt that the expansion of the scope of practice for nursing in Brazil and all of those challenges that we need to tackle for the creation, for the regulation, for the design, and for the development, and to make these practices effective at a national level. Certainly, it is extremely priority because it will expand the access to health for the population, and certainly it will strengthen the unified health system, SUS. And in our fourth meeting, we are going to know more about the experience, the nursing, advanced practice nursing experience from the USA with our dear speaker, Dr. Joyce. And I would like just to greet and thank everyone and Dr. Joyce for accepting this invitation to be here. Certainly, it will be enlightening and enriching to our discussions and to clarify lots of points and questions from our friends, our colleagues that would like to know more about these activities and how they are going and happening in other countries around the world. And I also would like to invite all the Brazilian nursing category. We have our second laboratory of nursing innovations, also an initiative in partnership with PAHO. And in this second lab or laboratory, we are closing within some weeks the registrations, and we'd like the nurses, the technicians, and the health professionals, the nursing professionals to present and to submit their work and their successful experiences that would impact the service and will impact the service, the health services that would be generating more absorption, better absorption of our clients that would be the healthcare. So we want to know more about these practices. We want the professionals to share and submit their initiatives and to submit their successful practices so we could share them, spread them all around Brazil and all around the world. And how the nurse professionals could be impacting the health institutions in services and in the care and receiving our population in the health units, but also in the land and the territories. So we would like to count with the participation and the registration and submission of the 3 axes, and nurses, technicians, professionals, please bring your work, share your work so we could be spreading them around and once again strengthening the nursing category work. Thank you very much, everyone. And I also would like to say that this work together with PAHO would not be possible if we did not have the support of Dr. Monica Padilla. I would like to thank you so much for this dedication and for everything that we have done together. It was with a lot of support and encouragement and incentive from Dr. Monica Padilla. This is a sincere recognition from all of us. Thank you very much. The nursing category thanks you for all the support, and let's continue. With this cycle of presentations will strengthen us and enlarge us for this discussion and debate and for our struggle and fight to regulate this nursing practice, the practice, advanced practice nursing. Thank you very much. A great day. Thank you, Nadia. Now, I'd like to invite Professor Dr. Maria Helena Maziali, Director of the College of Nursing from USP Ribeirão Preto, for her opening remarks. Thank you so much, Monica. A big hug to all of you connected here with us. It's wonderful to be with all of you again. Dr. Monica Padilla, Dr. Nadia Ramalho, Dr. Joyce, who is greeting us with her presentation here today. I see that this opportunity that PAHO Brazil is offering to the Brazilian nurses is so important, and we have to take advantage of it. We are now in our 4th week of debates and discussions, to look around the experiences. And we have here so important people, like Dr. Monica said, that have already trailed a pathway of success. Here in Brazil, as Dr. Nadia said, we already started this diagnosis, we already started some conversations and contacts, but we still have a long way to go. And this possibility that PAHO is offering us to put our efforts together so we can be learning with those that have already taken this way. So certainly this will help the advanced practice nursing history in Brazil. So the diagnosis of what we need to do, we already have the strategies. We know what would be the strategies. Now we need to plan and to work together. And this opportunity with every Friday to unite our efforts has been very important to strengthen our work. I see this based on the number of people that every Friday have been connecting here with us, joining us on the channels, and also the impact that we can cause. We are in a moment of media, and the media are saying, talking about the workshops. The medias are talking about the advanced practice nursing workshops. People are encouraged to study, to develop, to grow. So I see that we are with the result and the expectation is being reached at each meeting. And here, on behalf of the College of Nursing in Ribeirão Preto, USP, I would like to thank for this partnership. Great Dr. Monica Padilla, who had this brilliant leadership in this process, and the partnership with Cofen and all the other institutions. And I would like to thank so much Dr. Joyce for being here with us, sharing her experience. So we are very eager to hear to her, and I would conclude what I had to say. Thank you. Thank you so much, Professor Maria Helena. In this opportunity right now, I'd like to break the protocol a little bit to take this opportunity that we are now with everybody together on behalf of the whole technical unit of capacity building in PAHO. I'm sorry, but I am touched. It was not on the protocol, but I would like to thank all the effort by Dr. Monica Padilla and these actions for nursing and all actions that we have made in Brazil to support the human resource field in health. I believe we had a lot of advances in the last 5 years, so thank you so much, Dr. Monica, and I apologize for being so emotional. Thank you so much. We have the same feeling of emotions. And those of you that are watching us and don't know about it, she is our coordinator at PAHO, and she's being transferred to another country. We're going to be together at distance, but she's now, after next week, she won't be with us anymore here as the coordinator, but certainly we are going to count with her support. Now, going back, and we'd like to thank for the participation of our important partners that compose this group of advanced practice nursing: ADEM, CONASEMS, CONAS, Ministry of Health, Ministry of Education, University of Brasília, among others. But especially today, I'd like to thank the participation of Dr. Sergio Santos, the Director of Development of Education and Health from CESU, Ministry of Education. Welcome. Thank you so much for being here with us. And to Dr. Rodrigo Antaide, representative of the Secretariat of the Ministry of Health. Thank you so much, all of you, and also the other representatives with us during these events, and all the partner institutions that I just mentioned. So continuing, I now pass the word back to Dr. Carla Ventura, professor and director of the Collaborative Center of PAHO WHO for the Development of Researches in Nursing in the College of Nursing in Ribeirão Preto, University of São Paulo, to introduce our wonderful speaker and to moderate this panel. Thank you so much, Carla. Welcome. And Dr. Joyce, welcome for being here. Thank you for being here. Let's continue with this presentation. Thank you, Monica. Good afternoon, everyone. It is a great honor for all of us to have here the participation of Dr. Joyce Pulcini. She is the former president of the community of severe and chronic patients of George Washington University. She's been also the director of George Washington Nursing, Community Nursing and Global Initiatives. Dr. Joyce is an expert in the evolution of the roles of nurses all around the world, so with a focus on education of the nurses and political defense and the removal of barriers to the practice. For more than 30 years as a pediatric nurse, educator, author, Dr. Joyce has become a leader in policies in nursing at a local, national and international level. She's well known for her work in the development of advanced practice nursing. So I would like once again to greet and welcome once again Dr. Joyce. Thank you so much for this opportunity, Dr. Joyce, for accepting our invitation to be here and share your knowledge and your experience with us. Thank you so much, Dr. Joyce, and the word now is with you.
Thank you very much.
Yes.
Sorry, it just took me a minute to get this thing off the top. Okay, thank you so much. I'm so happy to be here with you today. My name is Dr. Joyce Pulcini. I'm at George Washington University, as was said, and I'm very pleased to be able to talk to you about the experience of implementing advanced practice nursing in the U.S. Okay, there. So I just declare no conflicts of interest. Okay. I'd like to start today to talk with you first about these guidelines that were implemented by the International Council of Nurses in 2020. This guideline just defines the two roles of the advanced practice of the nurse practitioner and the clinical nurse specialist and distinguishes the two. It was published by the ICN after 2 or 3 more years of work. And I was a contributing author on this document, and I would highly recommend that you use it. I have the website here. Again, it distinguishes the NP and CNS roles where there has been a lot of confusion. And this confusion occurred as a result of an earlier definition of advanced practice of advanced practice nursing that was a bit broad and really tried to account for the perspectives of different countries, but also led to some of the blending of the two roles and some confusion. So as a result, this document was created. So I'm going to actually talk about the definitions and characteristics of these two roles coming from the ICN. And then I will talk about the US and more specifically. So here is the definition of the advanced practice nurse, which is an advanced practice nurse is a generalist or a specialized nurse who has acquired through additional graduate education with a minimum of a master's degree, the expert knowledge base, complex decision-making skills, and clinical competencies for advanced nursing practice. The characteristics of which are shaped by the context in which they are credentialed to practice. The two most common APN roles are CNS and NP. A clinical nurse specialist is an advanced practice nurse who provides expert clinical advice and care based on established diagnoses in specialized clinical fields of practice, along with a systems approach in practicing as a member of the healthcare team. The CNS is more likely to work in specialized areas of healthcare and again to work on an interdisciplinary team. The nurse practitioner is an advanced practice nurse who integrates clinical skills associated with nursing and medicine in order to assess, diagnose, and manage patients in primary healthcare settings and acute care populations, as well as ongoing care for populations with chronic illness. The nurse practitioner is able to more independently manage the clinical needs for a patient and their families over time, and is more likely to work in primary care or community health settings, such as a clinic, health center, or office, but can also function in hospital settings with some independent functions. The educational preparation for APNs, the document says, is beyond that of a generalist or specialized nurse education and a minimum requirement of a full master's degree program. Formal recognition of educational programs for APN, CNS, or NP are present in the country. There's a formal system of credentialing linked to defined educational qualifications. So again, the ICN is clearly stating that the master's degree is really the educational level. In the US, just historically, I think it's important to remember that the first NP programs, nurse practitioner programs, were postgraduate certificates. They were not at the bachelor's level yet when we began. And by the 90s, we were at the master's level. And so now in the US, we are moving toward a doctorate of nursing practice, which is a clinical doctorate. So, but it took us, I'd like to say, 50 years to get here. So it's all a process and very important to think about it that way. According to the document says that the regulatory mechanisms for APN practice include the authority to diagnose, the authority to prescribe medications, the authority to order diagnostic testing and therapeutic treatments, and the authority to refer clients or patients to other services and or professionals. These are key components of the APN role. The authority to prescribe medications and order diagnostic testing often evolve in a country to be more and more independent. So again, in the US, we have moved to a higher level of independent practice, but we begin, I think, with less independence and move toward independence. A key factor here is to have solid research evidence that APNs can perform all of these skills. In the US, we found that even when these functions are well researched, resistance from the medical community can occur. Obviously, some of the medical providers react to the overlap with their own skills. Nevertheless, we must persist in order to make APN services available to clients who very much need these services. In the US, we have found this to be a never-ending struggle, but again, we do persist. The other characteristics are the authority to admit and discharge clients or patients to the hospital or other services so to refer as well. A country should have a title recognition or an officially recognized title for nurses working as APNs. and should have legislation to confer and protect the title, whether it's NP or clinical nurse specialist, and legislation and policies from an authoritative entity or some form of regulatory mechanism explicit to APNs, such as certification, credentialing, or authorization specific to that country's context. So, how did the APN implementation process take place in the US? And that was I was sent a series of questions, and this was one of the first one. And I think it is important to think of it as a process. I'm going to say that over and over again, because for us, it's taken 50 years to get where we are. So you have to start small and move out. But in the US, the APN role was started by a group of forward-thinking nurses who saw an opportunity to expand the role of public health nurses to meet the needs of underserved populations in the US. And in the beginning, many of those were in rural or in underserved areas of cities or towns in the US. We have 4 types of APNs in the US. And this isn't true in every country, but in our country, we have 4 groups that are called APNs. Nurse practitioners, as I've defined, clinical nurse specialists, again, as we've defined, and we have certified registered nurse midwives in the US. And then we have certified registered nurse anesthetists. And I'll give you some of the numbers later about how many of these exist in the US. But the first NP program in the US was a pediatric nurse practitioner program in Colorado, in the state of Colorado, in 1965, which focused on primary care of children in the community. And they used public health nurses to be the first students in that program. So these were experienced public health nurses whose role was going to be expanded, in that community. It was headed by Loretta Ford, a nurse, who many of you may have heard of, and Henry Silver, who was a physician. So they worked together to set up this program, which was first a certificate or postgraduate program, and later became part of the university program. So again, the first NPs were pediatric nurse practitioners, and later this evolved to other types of NPs. So here are the APN specialty areas in our country. And I've got some numbers here. There are more than 350,000 NPs in the United States right now, which is a huge number. And the majority of them are family nurse practitioners. 69 or so, almost 70% of them are family nurse practitioners. The rest are smaller numbers, between 8 and 10%. 10% adult or geriatric nurse practitioners, pediatric nurse practitioners, psychiatric mental health nurse practitioners who practice across the lifespan, children and adults. And that's becoming a really growing specialty with a large number of problems with behavioral health or substance abuse that we are seeing, or mental health problems. So this is a growing area. We have women's health nurse practitioners, a smaller number, and neonatal nurse practitioners who tend to work in neonatal intensive care units as specialists in the hospital. We also have acute care nurse practitioners, adult or pediatric, and they also work in hospitals. They work on a healthcare team and take on expanded roles, really function in many ways like medical residents in a hospital, but they do work collaboratively in a healthcare team in the hospital. So they're not independent in the way that the primary care nurse practitioners are, in a sense. So the clinical nurse midwives, certified nurse midwives, there are about 12,000 of them, many fewer. right. And in the US, as I'm going to say later, in some countries, the midwifery role is part of the RN role, but that is not true in the US. RNs don't learn to deliver babies in the US. So if they want to deliver babies, they become certified nurse midwives. And this role has broadened in that they cover almost all of prenatal care as well. So prenatal, postpartum care, as well as delivery. So it's around that whole perinatal period. Clinical nurse specialists, we have more than 72,000 of those, but not anywhere near the number of NPs. Again, they tend to work in hospitals, but they can also be in communities, and they tend to specialize in an area. Then there's a certified registered nurse anesthetist. We have more than 65,000 of them. And it's a very popular field. Again, they do give anesthesia and usually work collaboratively with an anesthesiologist. Often they do work in hospitals, for giving anesthesia. They also can work in centers where, such as colonoscopy centers, where anesthesia is given on an outpatient basis. So they may often be in one of those kinds of facilities. But it's quite a popular role, very highly paid, actually. And just to give you a sense of credentialing for these nurses, that we've had credentialing for many, many years in the US, and particularly certification. These are the organizations that certify the different specialties. And the nurse anesthetists have had certification or credentialing since 1941. So they've been around. They're one of the earliest specialty areas, actually, in the US. And nurse midwives have had certification since 1971. They both have very strong organizations that really oversee this process and really make sure that it's highly effective, highly consistent, and up to standards. For nurse practitioners, we have a number of certifying bodies. The American Nurses Association has certification, and that's the American Nurses Credentialing Center that does that. And they started in 1976 to certify nurse practitioners. Later, other organizations came in. That's the American Academy of Association of Nurse Practitioners. And then the National Certification Corporation certifies neonatal nurse practitioners and I think primarily neonatal and women's health nurse practitioners. And then PNCB is the Pediatric Nurses Credentialing Board. So they credential pediatric nurse practitioners. ANA has covered all of the areas as well. And then we have psych clinical specialists who also began to be certified in 1976. So I put this in because I think it's helpful to see really the scope. And my background is primarily with nurse practitioners. So a lot of what I'll be talking about is nurse practitioners, because that's where the depth of my knowledge is. But again, we have in the US more than 36,000 new NPs completed their programs in 2020. Their academic programs. Almost 90% are certified in an area of primary care. And 70% of all NPs deliver primary care, and 30% would be more in say, acute care or in other kinds of areas. So we, in the US, that primary care area is really the main focus. So 45% of full-time NPs hold hospital privileges, and 12% have long-term care privileges. The previous slide talks about Medicare and Medicaid, which is our insurance. NPs hold prescriptive privileges, and including prescribing of controlled substances in all 50 states and the District of Columbia. So there are some restrictions on those prescriptive privileges, but in every state, NPs can prescribe. And the base salary is relatively high. It's $110,000. The median base salary is $110,000, which is fairly high. The majority of full-time NPs see 3 or more patients an hour, and the majority have been in practice for more than 11 years. So they tend to stay in the practice where they are. They don't jump around. They're usually very happy with it, with the work that they do. And the average age, as in all nursing, is 49, which is high. You know, it's an older population. So what were the main challenges faced during the implementation of the APN role? In the beginning, and I was actually there in the beginning, to be honest, I'm very old. I became a nurse practitioner in 1974, which was a long time ago. And I began teaching in 1976 because I had a master's degree, and I was one of those people that was just a little bit ahead of the curve. So I was asked to teach very early on, and I did begin to teach, but always practiced for most of the years, because that's really at the center of the NP role, is that you must practice as well as teach. And kind of know what you're doing with students. But there were, in the beginning, of course, as you would expect, there was a lack of understanding of the role by consumers, by patients, by policymakers or legislative individuals and others, since it was a new role. And one of the things that helped the role was very early funding by the U.S. Department of Health and Human Services, the U.S. government. And they did, because and this funding came about because there were gaps in care in the U.S. for elderly people and people in rural areas and people in underserved or poorer areas of cities. And there weren't enough healthcare providers to care for them. So the funding was stimulated by the fact that there was a great need in the community for someone to care for patients. So it came from the need point of view, that there was a great need. And so the U.S. Health and Human Services initially funded both the certificate programs. They weren't university programs. The first programs were certificate or postgraduate programs, and actually directed one of those programs, which I closed ultimately because it was time to move it to a master's level. But in the beginning, these certificate programs were short length programs. Initially they were as short as 4 months, building on the knowledge of nurses, and then 9 months and a year. And again, the students were experienced nurses, like those public health nurses in the early days. Then the education moved to universities within about 10 years. And the government also funded those programs and also provided stipends for students. They had stipends to live while they were in the program. There was such a need. So there was a lot of money really from the federal government to get this going. And I would credit that very much. So the certificate versus the university programs, there was a great need for these early certificate programs, but gradually they moved into the mainstream of nursing, into university programs. The certificate programs often had co-leads of a nurse and a physician, like Dr. Ford and Dr. Silver. And in the program I taught in the early days, we had as many physicians as nurses as faculty, because again, there weren't enough there in the early days, there weren't enough experienced nurse practitioners to teach. So we needed to use physicians to teach with us. And they were wonderful colleagues. The physicians who worked with us were just wonderful colleagues and really believed in the role. And in the program I taught in, students had to have a place to practice, had to be working in a practice that was going to embrace this role. And so we had actually had programs to educate the practicing physicians where these nurses worked about the role and about how to help these students through. So we had a very close relationships with the clinical practices in the beginning, and that faded away as the need changed. But I think was a very important foundation, I think, for the role, because we helped the practices to really, the clinics to really understand how to use nurse practitioners appropriately. And we mentored them and visited them, even went to the practices and visited them to help them. The opposition, no surprise, was, as time went on, especially was from physician groups who felt threatened by this role. And that continues today, but we always have lots of physicians who really work with nurse practitioners or clinical nurse specialists who are also their champions. So we have, not all physicians are against it. It is the ones who know less about it. And in the beginning, I will say a lot of other nurses were opponents. Nurses were threatened by the fact that a nurse practitioner would take on these roles, and we were called mini doctors and told that we shouldn't be doing this. But that opposition went away as I think greater understanding of the role came into place. Even the nursing organizations didn't understand this, and some universities did not really want to have nurse practitioner programs. So we had to go through a process of convincing universities that we needed to be in those universities and in the mainstream. I remember actually very, very clearly around 1993 when kind of we reached this tipping point, and almost every university who had a nursing school wanted to have a nurse practitioner program and did have nurse practitioner programs. So we reached this tipping point of understanding and of evolution, but it took a long time to get to that place. So by 1993, almost all schools of nursing had nurse practitioner programs or other APN programs. So the question being, what is the difference between advanced practice nursing and MD practice or RN practice? And I'll start with the MD practice, because APNs, as I always describe it, take on roles that were once in the realm of medical practice and now are part of nursing practice. Those roles overlap and incorporate them into nursing practice. And those roles are assessment, diagnosis, and treatment of illness. Now, advanced assessment, because all nurses assess, obviously, but advanced assessment and diagnosis and treatment, that is prescribing, treatment and prescribing, and referral for that matter. So APN, I always say that the APN practice gives patients access to nursing care. In other words, if you're seeing a nurse practitioner, you get the kind of traditional medical care quote that you need, but you also have access to an experienced nurse who is going to look at you holistically, take care of you and your family, and really understand that whole patient. So the nursing part doesn't go away. It's actually right at the center of APN practice. And really the APN practice allows patients access to one person who can do all of that. In the case of CRNAs, for example, the difference is giving anesthesia. So there are nurses who now give anesthesia. But the location of practice may differ. And for example, as I've said, I think I've emphasized, in the US, most nurse practitioners work in kind of in primary care. I've noticed as I've gone around the world that a lot of countries are beginning an APN practice in the hospital, which is fine, but it's the degree of independence is different in a hospital because you must work really very collaboratively. So again, I'm a big fan of, I do believe that primary care is an important place for us to begin. And NPs can function, as I said, as acute care nurse practitioners, and have talked about how they manage critical care patients, similar to medical records, but in collaboration. And the acute care nurse practitioners often have to have at least 2 years of practice in an ICU, be very experienced, RNs in a hospital setting before they can even enter one of these acute care programs, because they're highly technical and they're really taught a very high level of skill. I think I've said some of this before, and about midwifery is not part of RN practice in the US. So really, what is the difference between an RN and an APN? I mean, the difference is that in those skills that overlap with physicians, the expanded role or extended role that we talk about, those expanded skills. So all nurses assess, but it has to do with the level of assessment, the depth of assessment, and APNs will diagnose and treat illness in a similar way that physicians do. So I'm not sure if that's clear, but that's how I describe it to people. I was asked, what competencies and skills should the advanced practice nurse learn in the training process? And what I've put here are the organizations that put out competency statements. And the American Association of Colleges of Nursing has put out, is a major organization that does competencies and the essential documents for, previously the essential documents for master's and doctoral education. Now they've combined those into this new document that is called the Essentials Professional Competencies for Nursing Education, and that is a new document. The National Organization of Nurse Practitioner Faculties, an organization that I've been very involved with for my whole career, also does competence, has provided competencies, and you can see them listed here. The National Task Force criteria for evaluation of nurse practitioner programs are not competencies, but they are what characteristics would be necessary in a program, in an educational program. So they're really not competencies, but they carefully list out what those programs should include, what the educational programs should include. And these criteria are followed by our accrediting body, the CCNE. So I'm also a CCNE visitor. We use the National Task Force criteria, as we call them, to evaluate the school that we're accrediting. So they're very important and they're part of the whole CCNE process. So NOMF has also provided very specific competencies. We now have doctoral level competencies for APNs, for NPs that we use, because we've evolved now to be almost at the doctoral level. What does the curriculum look like? I hope my time is okay. Am I doing okay with time?
Yes.
I am, okay.
Yes.
So what is the curricular structure of a master's degree for the training of advanced practice nurses? And so these are the core of a master's program, not the doctoral program, but the master's program, because that's what I was asked. So all of them have what we call the 3 Ps. advanced pathophysiology, advanced health assessment, and advanced pharmacology. And these are across the lifespan. They must be across the lifespan from infancy to end of life. And then we have core courses, and and these are examples of some of the core content that might be a health policy course, a course in leadership and nursing leadership. Content in healthcare quality is incredibly important now these days as we try to measure outcomes in healthcare, and of course, research courses or evidence-based nursing courses. Those are part of the master's degree. And we usually incorporate role, that is, how do you change your role and become from a nurse to a nurse practitioner, or a nurse to a clinical nurse specialist, and so forth. And that may not be a whole course these days, but it's incorporated in. And then, of course, specialty clinical courses, 3 or 4 very intense specialty clinical courses that are population focused and discuss the management of illness, management of disease by the nurse practitioner. So those are often organized by system, by body system, but those courses really get into the nuts and bolts of treating, assessing, and diagnosing. In the US, we have the LACE model, and it was developed in 2011, but it kind of creates a kind of a hierarchy here. So there's the graduate core courses, and then the APRN courses, such as the 3 Ps, and then role courses, and then population focused specialty courses. If the population focused courses or specialty courses. And I'm going to talk a little bit about that in a minute. So this model that we have used in the US says that there are 4 at the bottom up, going from the bottom up, that there are 4 APRN roles, which I've described: the nurse anesthetist, the nurse midwife, the clinical nurse specialist, and the nurse practitioner. And then it lists the types of NP programs that a school can have. But, those are 6. So they don't, if you're interested in educating a nurse practitioner to do oncology, for example, or a specialized orthopedics or neurology, palliative care, those are over and above the NP program. Those go beyond. So they have to go to get a certificate afterwards if they wish, but it's not required. So again, we kept it broad as the types of NP programs that we would have to make it consistent. And again, we're dealing with a huge country with 50 states, and we were getting all these types of NP programs that were too specialized. So it's not that we don't want that, but it is over and above the basic NP program. So again, palliative care, oncology, orthopedics, neurology, whatever, are extra in a way. So what are the strengths and weaknesses for implementing the APN? And again, I think we're seeing that in the US, and I don't know if that's true where you are, but we have fewer MDs who want to be primary care specialists. Why? Because they're paid the least. The lowest paying physicians are in pediatrics and internal medicine. And those are primary care specialties or family practice. So those are the lowest paid specialties. So physicians in the US are choosing higher paid specialties, such as cardiology or, whatever, dermatology or respiratory. So again, we've always had a gap in primary care. And the NP really extends the workforce to allow patients to receive more and better care. And over time, the level of satisfaction has truly grown tremendously in the U.S. You talk to everyone now knows what the nurse practitioner means, what that is. And many people will say, I have a nurse practitioner. I love them. I'm so happy that I have this nurse practitioner who takes more time with me, who pays more attention to me. And patients tend to really like that extra nursing care that they get as a result. Excuse me, studies have shown that the NP in primary care is equally effective as the MD care. So in primary care, we can provide up to 90% of the same services as NPs in those settings, in those primary care settings. So again, in primary care, it is a very effective role. And we have lots of data now to show that it works. We have not all states have what we call full practice authority or full independence to practice. About half of them do. And we continue to work on that state by state. But the reality is in the US, we have 50 different sets of regulations because we have 50 different states and each one does it a little differently. For better or for worse, that's the way it is in the US. So again, regulations differ slightly from state to state. So there's not complete consistency across the states. And generally, this kind of thing is not regulated from the federal level. So I was asked, what is the definition of the nurse practitioner? And there isn't one in the US. Each state really has a legal definition of these roles that's put into the legislation. And they each have their own rules and regulation governing these roles. So most people tend to practice in the US. It's hard to transfer from one country to another when you're talking about this kind of thing. We do have, as I said, very highly regulated, highly developed certification exams in the US. They're required in almost every state to practice. They are really the entry-level examinations, and recertification is every 5 years. And they use very sophisticated mechanisms to develop their exams. They work together and use the same kinds of processes to do this. And there's a lot of collaboration after all these years of nurse practitioner educators, certifiers, accreditors, and practice organizations. They talk to each other in the US, which is amazing when you have such a big country like this. So we have a lot of agreement on these things, and we have a problem. They come together and talk, or if there's a need to change standards, we try to get together and talk about those. How autonomous? Again, autonomous is a difficult word. You know what's autonomous mean? It's something that you evolve toward. I think that's what I'd like to say. It isn't that no one is autonomous. We all work collaboratively. No matter what your regulations say, you're going to work collaboratively with the physician that you're working with. But we don't believe that we should be dominated by the medical profession, that they should say what our profession is. So we're our own profession, and we have our own standards and regulations. So we don't believe that physicians should rule over our practice. That's period. Many national commissions have recommended full practice authority. Most recently, the Future of Nursing report 2020-2030 that was put forth by the National Academy of Medicine, and Sue Hassmiller was one of the key people working on that. So I'm gonna say again, it took us 50 years to get to this point. It took a long time. So you start in the beginning and you move, and it's a process. So as not to think that anything happens overnight. I think of it as concentric circles, and you have more autonomy, and then you build more. And more.
Recording in progress.
In the early days of practice, our scope was very narrow. I was a pediatric nurse practitioner. We had guidelines, and we had only a certain kinds of medications that we could prescribe. It was very limited in the beginning, and over time we learned to be have more and more skill. But it wasn't that way to begin with. It took time to develop that. I hope I'm not getting over my time here. So is there a career path for advanced practice nurses? I'm asked this a lot, and I think in some countries, when they think about a career path, it's thought of as being a move into administrative roles. In the US, APNs tend to really like what they do. And they actually are not interested in being managers or administrators. They like to take care of their patients because they're so satisfied by this role. And so I have a friend who's been a nurse practitioner, just retired after 35 years of practice. And she'll talk about how she's known these families for 35 years. These patients, and known their children and their children's children, So it's a very satisfying thing to have this, have this primary care practice. So some do move into administrative roles, but and I've had many of them move in and out of those roles because they'd rather be in clinical practice. So again, also the pay is very high. So the median salary for nurse practitioners is high and very respectable. So maybe not that much more than an administrator in reality. I'm sure you also know that in the US, nurses are the most respected profession for the past 17 years. When they rank professions, nurses, not just nurse practitioners, but nurses are the most respected profession in the United States. So people respect you, you have status, and you're paid well. So status and pay are very important, I think, to keeping people in these roles. So finally, how do you project the role of nursing for the future of your country? As I've said, nurses have been the most trusted profession. It's been consistent. Nurses are very highly regarded, and I believe, that the APN role is very much a part of this, because there's women choose the profession because it has higher status and because it has good pay. Pay is very important. And so for that reason, we have been attracting the best and the brightest of nurses into this field, of young women into this field. And young nurses kind of get this. They get what we're trying to do. They get that they need to expand their role and be more autonomous. And they're very interested in this role. In fact, many of them choose nursing over medicine. Very common for nursing students to say, I thought about being a doctor, but I really want to be a nurse. And that's, I think, evidence of the accomplishment, and that a young person coming into nursing knows that there is a hierarchy, and that they can go to the advanced practice roles if they wish. We've also attracted many males into the profession. And I'm happy to say that my son is a nurse. He just became a nurse last year. So I have observed the status continually to be rising over the years. And I think it has a lot to do with the APN. I think I've said much of this. once they get in, actually the pay for nurses is, nursing is one, there's RNs, bachelor's level nursing is one of the highest paid jobs for nurses, for new graduates in the US. Obviously, that pay doesn't continue to accelerate in the way maybe for a lawyer or even a physician, but they are highly paid and people know that. We have second degree, many nurses come into nursing having had a first bachelor's and choose nursing as a second bachelor's or then go on to the master's. So for many, nursing is a second career, highly chosen when they're an adult. So just to finish up, COVID has had a big effect on nursing and on nurse practitioners. We've seen a great deal of burnout, and as I'm sure you have, and high stress. And many have left the field. And so we had a lot of older nurses who were nearing retirement who left with COVID and just with the stress of all of that. So the challenges, well, we're going to see shortages ahead. So finally, here are some websites that I put up and a few references that I mentioned here. And are there any questions if there's time? It's 2:11, so I think I'm going over.
Muito obrigada, doutora Joyce. Compartilhando.
Thank you so much, Dr. Joyce, for sharing with us all of these experiences. We have several comments here in the social media, on YouTube, congratulating you for this outstanding presentation. And we have here some questions.
Good.
Well, one of the questions, the starting question, Dr. Joyce, is about, well, how this clinical practice would be. How many hours of clinical practice? Who supervises the nurses in this formation?
Are you talking about students, or because the nurses are we supervise a nurse practitioner working in a practice would have a supervisor, but it would be a nurse. It wouldn't be a physician.
A nurse.
Yeah.
This is another question, né? Uma outra pergunta aqui sobre quem é.
There's another question on who would be supervising the nurses.
They work collaboratively with physicians. So they might ask a question, they might get to a point where they can't solve the problem, and they certainly would collaborate with a physician. And sometimes the physicians collaborate with the nurses and ask them questions, right? It's a two-way street, and they work collaboratively. But absolutely, if they get to a point where they don't understand something, they need to refer. They certainly will talk to a physician or refer to another specialty area. They might refer to a cardiologist or a respiratory therapist or whatever, dermatologist. So absolutely, we have a highly specialized group of physicians in our country. So it's very common for a primary care provider to make referrals to specialists. Yeah.
Muito obrigada, doutora Joyce.
Thank you so much, Dr. Joyce. And also the next question is about the number of weeks of the disciplines, of the subject, of the program. How many weeks for each discipline or each subject?
I think that varies. The curriculum isn't that rigid that we tell them how many weeks, but they must cover this content. The programs are usually 2 years in length, between 1.5 years to 2 years in length, usually about 2 years in length at the master's level. Yeah.
Uma outra pergunta.
Another question that we have in the Brazilian case, we are in early process for implementing APN. What would be the best pathway for choosing the level of care for the formation of this profession? Primary care or hospital level?
Well, I think you've heard my bias on that. I strongly believe in primary care. I think the best way to start is in primary care, building on your RN knowledge, and nurses really shine in primary care. They already have so much knowledge to begin with. When they come to a program, they just build on that knowledge. So that would be my answer.
Obrigada. E como
Thank you so much once again. And how do you negotiate or these barriers in the beginning? Mainly mainly with the medical associations and the nursing associations.
Well, we have strong nursing organizations with lobbyists and whole big staff, and they often well, we try to be, we're polite with each other and so forth, and we expect certain level of resistance, but we almost expect it, so doesn't bother us anymore. We just keep going. We persist because they have to be educated. And physicians are smart, they can be educated too. And often when they work with a nurse, advanced practice nurse, that's when they're really educated. Then they see what they're able to do. And so it's a process. It's always a process. And we try to be, we're polite, but we do keep going. We persist. Yes.
E nesse processo,
And in this process, Dr. Joyce, there were moments where you could observe step backs. Could you talk us a little bit about these experiences, negative experiences, and these step backs during the 50 years of consolidation of the practice, APN in the United States, in moments where there were problems, issues, step backs, and how did you overcome these barriers and problems and issues?
I don't know. I directed a certificate nurse practitioner program, and that was in the 70s and early 80s. And we realized that we had to move this to a master's level. And the university that I was teaching in was not ready for a master's degree in this field, in this area. So we had to close the certificate program. And it was in the same university, but it was separate from the School of Nursing in a way. So we had to close that school. I closed it because I didn't think we should have sought more funding for a certificate program when it was time to give these nurses university degrees. So I actually went and got my doctorate, and I taught at the Boston University, where I was directed the master's programs, and that program, oddly enough, closed. And we brought the same program back to the original university where I had taught. So I helped to start that program that I had wanted to start back in the early 80s. So I could see that circle. That program went full circle and actually became a master's program and exists as a strong program today. So those were setbacks. Closing schools were setbacks. But
e no curso de
And
graduação,
in the graduation course, the nursing course, let's say, how do you announce this role or this possibility of the nurse acting in the APN roles?
Well, we try to teach them how to negotiate their role. We help them to negotiate this new role with nurses or others in the practice. So we teach them the language of how you do that in a way that's collegial and helpful. We teach them to expect some resistance, but to learn how to overcome that resistance without giving up. And it's all about education, and it's really all about treating people with respect, understanding where people were coming from. You help people to understand what you're thinking, what you're talking about. So we don't have to do that as much now as we did in the early days, because people understand this role now. So it's changed so much over these years.
obrigada, doutora Joyce.
Thank you so much, Dr. Joyce. I don't know if Dr. Monica Padilla would like to make a question. Yes, Dr. Monica? Thank you so much, Joyce, for all this experience shared. I would like to ask then, well, the people that are in nursing and not the other specialty courses, the role, lots of times, And the advanced formation is associated to a formation like an additional residence. If you stay only on graduation courses, what would be the role that these professionals would reach? Because the question is if the advanced practice is associated to the certified practice, as you could see. So could you tell us a little bit about this point? A good nursing will be, this course would be enough?
About a residency, postgraduate residency? Is that, I'm not sure I totally understand the question, but.
Because a pergunta es que si você tem
The question is if you have a set, a moment in formations, you have the nurse, if you take the basic course and you become a nurse, just a nurse, but afterwards you have to take several courses to become in the line of advanced practice, right? And the question is, APN is associated only to post-basic graduation courses, or if the basic graduation is already enough, reinforcing the capability enough to go to the advanced practice.
Okay. Yeah, when they graduate, they're really beginners. We know Benners, from novice to expert, right? And so they're novices when they graduate. And that first year of practice is a residency, whether you call it that or not. They're learning. They continue to learn. And hopefully the practice is setting it up so that they are supported, that they can ask questions, that they're not seeing too many patients to be totally overwhelmed. But sometimes that does happen. So we have formal residency programs now, postgraduate residencies for nurse practitioners. And for many students, that works really well because the complexity of practice has really increased. And the numbers of patients they have to see on day one has really increased. So even though they pass that certification exam, they're not really ready for right away. They're novices and they have to proceed to be experts. Yeah, good.
Muito obrigada, doutora Joyce.
Thank you so much, Dr. Joyce. And to close our session, we'd like you just to give us a final message for the Brazilian nurses that we are starting this consolidation process. So could you just pass us this final message, please?
Well, I'll say, congratulations for what you're trying to do. It's a big job. I understand where you're sitting because I was there in the beginning in the US, and it's very formidable. But to remember that it's a process, that you're going to take one step and move forward and try not to pay too much attention to the resistance, but enough so that you can keep going and to persist. Always stick with it. Persistence is really what you have to do. And I think you're going to see a very positive outcome. It's a very interesting journey, but it's worth it. Yeah.
Muito obrigada.
Thank you so much, Dr. Joyce. And I would like to once again thank Dr. Joyce so much for the presentation, for being here with us, sharing her experience and knowledge. Lots of ideas were shared, and it was very important and a very educating presentation with these experiences and showing us this huge challenge that we have ahead of us and that we should now deal with. So thank you so much. And I now pass the word back to Monica Durães, please. And before, I believe that we could, well, before concluding, could we take a picture, a gallery picture with everyone in the group? Can we turn on our cameras to take a gallery picture? So if you could please open your cameras so we could take a group picture with everyone, please. I'd like to thank everyone for the participation. We are very happy, and I believe that Monica is in another machine. Is in another computer. But okay. So we are still missing Rodrigo and Betty. Carla, you're gonna take the picture. I was going to ask Juliana to take this picture, please. Juliana, can you do that for us? Juliana, Betty. We're still missing Betty on the picture. Thank you so much. I think Monica's computer has some problem because she's not being able to open her camera. I'm on the phone. Can you see me here? I'm on the phone. Yes, we can see you. Wonderful. Wonderful. So, Carla. Okay, wonderful. Thank you so much, Dr. Monica. Thank you so much, participants, everyone in this room with us, and all the participants and viewers on YouTube. Thank you so much for being here with us once again. And I'd like to invite you for our next meeting that will be on November 5th. And we're going to have then the Mexican experience about this APM implementation process there. So thank you very much, everyone. Thank you very much, Dr. Joyce. And I wish you all a good afternoon. Bye-bye. Thank you very much, everyone. Thank you, Dr. Joyce. Bye-bye.